with this one, the unstable DRUJ?
Yeah, this is the second one, sir.
It doesn't matter. It's come up. Should we do this one?
Yeah.
Let's do this one. So I'm David Warwick. I work in Southampton, which you can see on the map there is right at the very bottom of the country, just there. And I currently, well, I've been there for a long time, actually. And this is a topic that I've been interested in for a long, long time. And when you get interested in a topic, you get lots of people come and see you about that topic. And there's one or two things here. I got involved in a couple of textbook chapters in the past on this particular topic. And I'm going to share with you for the next sort of 35 minutes or so, some of my thoughts about how we look at this unstable distal radio-ulnar joint. And at the end, we've got lots of time for as many questions as you like. Now, if you get an unstable distal radio-ulnar joint, then there are a number of things you can get. Firstly, it can be painful. The other thing, it can look deformed because the ulnar head here will be unstable and prominent. The wrist can clunk as you turn it around. And because grip also pulls the two bones together, you can feel quite weak. You have inhibition of grip. And interestingly, about 20% of people have some symptoms in their ulnar nerve. And this is a paper from Paul Malone and Vivian Lees in Manchester. And this is a CT, an MR scan. You can see on the bottom right how, if there's an unstable DRUJ, how the ulnar nerve can be irritated by the movement of that unstable joint. So this is how I think about the unstable DRUJ. And essentially, we're going to look at the anatomy, which is always important. And then we'll look at the causes of instability and how we can treat it. So let's look at the anatomy first of all. Now, the first thing is the shape of the sigmoid notch, because the sigmoid notch is flat on the radius, but perfectly round on the ulnar. So there's a natural instability between these two bones, because as you rotate, the ulnar actually slides a little bit anyway, backwards and forwards on the sigmoid notch. And some people have a very shallow sigmoid notch, which make it more likely to slide backwards and forwards. And that's something to bear in mind, the way that this joint can slide backwards and forwards. And because of that, just like the shoulder, for example, it needs to have ligaments to make it stable. So the bone itself is not a good enough shape to be stable. It's not a stable socket joint like a hip joint, for example. So the ligaments and the muscles are very important. So if you look at the distal radio-ulnar joint, first of all, you will have the capsule, the joint lining. And secondly, you'll have the triangular cartilage, which has got an anterior limb and a posterior limb. And I sort of show people when we teach them, if that's your wrist here, and there's the anterior and posterior limb here, how they go either side of your distal radio-ulnar joint, like this, gripping the ulnar head and the radius so that it can turn around without the ulnar head dislocating. So that's the TFCC. And finally, up the side here is the ulnocarpal ligament and the ECU sheath. And this is a very strong structure around the side here. So you have the ulnocarpal ligament and the sheath where my fingers are here. And you have the TFCC at the back, and you have the TFCC running across the front here. So that's the ligaments, but there's also muscle pull. And you'll know, of course, that many joints are stable because of the muscles that pull across. And in the forearm, there are lots of muscles, you can see Leonardo's pictures there, which actually run obliquely across from the ulnar towards the radius. So the thumb abductors that bring your thumb out, they all run across obliquely. FTS runs slightly obliquely, pronator quadratus completely transversely. And these muscles have tone, and these muscles are always pulling these two bones together, the ulnar head and the sigmoid notch. So this joint is fairly stable as long as the ligaments and the muscle and the bones are all working together to keep it stable. There's a picture from our textbook, Apley and Solomon's System of Orthopedics and Trauma. The There's the new edition of the Concise is coming out early next year. And again, you can see on this picture how you have the TFCC at the front, the palmar radioulnar ligament, the ulnocarpal and the ulnolunate ligament and the sheath of ECU. And at the back, there'll be the dorsal radioulnar ligament. So the TFCC, the triangular fibrocartilage complex, is complicated, but essentially it clasps, it grips this side of the wrist and keeps the ulna against the radius. Now, if any of you want to look at a particularly good article on the anatomy of the TFCC in much more detail, then I'd recommend this article from the Journal of Hand Surgery European, which, as you can see, has got the most beautiful drawings of this complicated structure, done by Martin Langer, who's a German plastics hand surgeon who does a lot of these just perfect anatomical pictures. So we've looked at the DRUJ here distally, but what you've got to remember is that also the forearm is a longitudinal joint. It's a longitudinal joint, which means that you have to think about the whole joint together. Because this longitudinal joint is not just the distal radioulnar joint, but it's also the proximal radioulnar joint, joined together by the interosseous membrane and joined together by the TFCC distally, down here, and proximally joined together by the annular ligament around the radial head. And the other thing to remember is that the radius hangs from the ulna. We keep thinking it's the ulna that's unstable and the radius is sitting there, but that's not true. The ulna is the stable bone because the ulna is fixed by a very strong hinge at the elbow, and the ulna is fixed. And when you turn the forearm, it is the radius which actually turns around, not the ulna. So the radius, just like this monkey, the radius is hanging from the ulna. So it's hanging from the ulna with the proximal radioulnar joint, with the distal radioulnar joint, and then there's the interosseous membrane in the middle. So the ulna is the solid bone. And this is important, as we'll come to in a minute, because if people do silly things like a Dirac procedure or like a Sauvé-Capangé procedure, they're very, very bad operations because you are actually taking the end of the branch that the monkey is hanging from if you cut out that ulnar head. And the other thing, when we're talking about this longitudinal forearm bone, is that as we've evolved as humans, one of the things we can do is rotate our forearm around. And rotating the forearm has made our hand much more useful, because if you can rotate your forearm, then you're able to reach out and grab things. You're able to pick things up by supinating. You're able to swing weapons backwards and forwards. You're able to use your hand as a tool. So this stable rotating forearm has developed over time, along with our opposing thumb, to give us a limb which we can use as a tool. We can use our limb to create an environment for us. So if you think about this circular forearm joint, this longitudinal joint, if you disrupt one part of this, you make the whole thing unstable, which is why excising an ulnar head gives you an unstable forearm. A Galeazzi fracture or a Monteggia fracture, or if you have an unstable proximal radial head fracture, any part of this longitudinal joint can, if you damage one bit, you spoil the whole thing. Just like these polo mints, you can't just break a polo mint in one place. If you break it in one place, the whole polo mint will be broken. So just the terminology then, in books, we often say, oh, the dorsal dislocation of the ulna when it's unstable. Well, that's not true. There's nothing wrong with the ulna. The ulna is not dislocated. The ulna is stable. In fact, what we have is a palmar dislocation of the radius. When you examine the forearm for instability, I know we move the ulnar backwards and forwards, but actually that's not what we should do or are doing. What we should actually be doing is moving the radius backwards and forwards because the ulnar's fixed. So it's interesting to remember that terms that have been used for many years, dorsal dislocation of the ulnar, is actually wrong. And now we understand that because we all understand together the anatomy that we've just discussed. So that's the anatomy of this joint. It is naturally unstable, but because of the bone shape, but in particular because of the TFCC and the muscles pulling across, it becomes a stable joint that can rotate through 180 degrees. But if something goes wrong, then it becomes unstable. And when it becomes unstable, you have a very, very big problem with your forearm because you can no longer hold your hand in whatever position of rotation you want in a stable position. So let's find out why the joint becomes unstable. First of all, iatrogenic. Doctors can make the joint unstable. Okay, we've got to be very careful what we do. Doctors can make the ulnar head unstable. There's lots of procedures. They've all got someone's name where we take off the ulnar head. We chop off the ulnar head. There's Dirac, Bowers, Watson's, Baldwin's, Sauvé-Capangui. They're all different versions of taking part of the ulnar away when there's a forearm problem. But all of these operations have got problems because cutting off the ulnar head, as we now understand from the anatomy, is a very bad choice. So if you look at some of these deletions here, you can see this, which is a matched resection. You can have, here's a matched resection here. You can see how unstable it is. The big gap here is that bone is clacking backwards and forwards because the head no longer fills the gap. In the middle is a Dirac procedure, and you can see how over time the radius has ground out a scallop against the ulnar. You can see on the right, this is called a Baldwin procedure, which is little known, but it's like a Sauvé-Capangui, but without actually fixing the ulnar head. So it's just taking out a little bit of bone here. So all of these make the forearm joint unstable. Dirac procedure, you can take off too much on the left, and you can take off too little on the right. You can see how that bone is cutting a groove in the right-hand side here into the sigmoid notch. It's like Goldilocks having too much porridge or too little porridge. And we know that Dirac's is a bad operation. At least 4 papers, a long time ago, some of these, telling us that if you do a Dirac in trauma or osteoarthritis or younger people, the results are not good. And they're not good because you've spoilt this joint. Now, the Sauvé-Capangui, 20 odd years ago, was thought to be, oh, this is a good operation. If someone's got a stiff forearm or an unstable forearm, you can do a Sauvé-Capangui, where you remove a little bit of ulnar here and you fix the head into the radius with a screw or some wires. But this is the devil's operation. And I've seen a lot of people who've had a Sauvé-Capangui in good faith, which has led them to a dreadfully unstable arm, a really unstable forearm. Because at this level here, there's nothing to support the ulnar or the radius. And if you do what Louis Schecker described with these operations, a Dirac or a Sauvé-Capangui, if you actually have the patient with their ulnar down here, holding a weight, a 5-kilo weight or something, and then take an X-ray, this is what you see. You can see the ulnar stays where it is, but the radius drops down and hits the ulnar. And that's what we mean by impingement. But if you do a simple X-ray with someone who's had one of these operations, you can't see this. If you do the loading X-ray, now you realize the problem that's caused by these operations. Now, the Sauvé-Capangui or a failed Dirac's are difficult to salvage. So here was one, and about 15 years ago, an idea was you just put an ulnar head replacement in, And sometimes, if there's still some soft tissue left behind here, you can put an ulnar head, you take out this bone and put an ulnar head in the envelope. And if you're lucky, you can get some stability. And you can see on the right how this has carved itself a new rim, a new notch just here. But that doesn't always work. Here's one that just didn't work. Again, a cervicophalange. Here's another one where this patient was in terrible trouble from an unstable forearm. Then a new procedure came along, the spherical ulnar head, and the idea was in a cervicophalange, you make a reamed space here where the ulnar block is, and you put this head inside, so it's got a bony socket here. Now, they didn't do many, and I'm not sure you can get this anymore, but the idea is that you had some bony stability. Here's one that I've done. And you can see how you have to cut the radius, first of all, in order to open up the ulnar head so you can get the implant in and then bring the radius down on top. So it's complicated, but there you can see this head inside the previous bone block. Now, I don't know how durable that is in terms of wearing out. And the solution really now is this. If you have a cervicophalange that's failed, the reliable procedure is this, which is the Shecker total DRUJ replacement. And you can see how this now restores a distal radial ulnar joint link. And we'll come back to this implant a little bit later on, the Shecker. So in summary so far, don't remove the ulnar head in trauma or active people if you don't need to. Sometimes there's a better option. You can repair the TFCC, for example, or you can replace it with a primary replacement. We've done quite a lot of ulnar head replacements in Southampton. This paper was with my colleague Eleni. 7 years ago we published this now, but we looked at 52 of our ulnar heads. We've done a lot more than that now. And the problems are good. So pain 2 out of 10, the DASH score 18, which isn't bad. And 47 of the patients we reported would have the procedure again, an ulnar head replacement for their pathology. So for example, if you have distal radial joint arthritis or a completely destroyed ulnar head, to replace the joint rather than just removing it is a viable option. Now there's a philosophy here because you can take out the ulnar head, and if it becomes unstable, the forearm, then you could then put a replacement in to retrieve it. Or if you take out the ulnar head, you can put the ulnar head replacement in straight away to maintain that forearm stability. So that's iatrogenic. That's how we try not to make it unstable and to make it more stable if we can with ulnar head deletion. If we look at acute instability, this is where the ulnar head hasn't been damaged because a surgeon's cut it out. This is where the ulnar, or the radius, of course, not the ulnar, but the radius becomes unstable because of an acute injury. Now we know about the Essex-Lopresti lesion. Peter Essex-Lopresti was in Birmingham, and he described this, where if you cut out the radial head, that can cause instability right the way down the forearm. Remember my monkey hanging on the ulnar? So this is the monkey hanging on the ulnar where we've cut the proximal end of the branch. Here's one here where you can see on the left, the radial head's been removed. And on the right, you can see how the ulnar is now butting up into the carpus. Difficult to fix an Essex-Lopresti. The key thing is not to do it in the first place. So if anyone has broken their radial head, check very carefully if they've broken their radial head that they haven't got pain down here along the interosseous membrane. And if they do, don't take the radial head out, keep it in, or try and repair it with any sort of screws you have so that everything stabilize. So do be careful if there's a radial head fracture not to excise it unless you're absolutely certain there's no tenderness and instability through the forearm joint. And repairing it's difficult, but we do an ulnar shortening, osteotomy to tighten the whole membrane up, and possibly a radial head replacement, although after a couple of years, it's impossible to do a radial head replacement. There's no room. And it may be possible to repair the interosseous membrane. Never excise the ulnar head. So one of the problems is people say, look, the ulnar is pushing up into the carpus. Let's excise the ulnar head. Well, see, that's a silly idea, because if that happens, because there's no interosseous membrane, all that happens is it'll move a bit further and make it worse. And there's the thought of trying to repair the oblique bundle as well for less exopressity using a tendon graft so that you can, again, stop this instability when you've lost your radial head. Now, the Galeazzi fracture, we all recognize that one. You see what's happened to the DRUJ? It's an acute injury, but all you've got to do is to fix the radius with a good strong plate, and the DRUJ is almost always stable afterwards. Even though there's a bit of a gap, for some reason, if you fix the radius, the Galeazzi, it's fixed. So fix the radius perfectly, and the Galeazzi is usually mended. An isolated DRUJ dislocation is rare, usually associated with polytrauma, because there's a lot of energy, but that needs to be reduced. It can click back. Sometimes you have to open it up and take out the soft tissue. And either way, when it's back, you probably need some wires to hold the two bones together till the soft tissue heals. And here's just a clue for everybody when you're listening, is this: if you put wires across here to stabilize it, don't put them across the joint. I've seen a couple of people where the joints become infected, and that's not good. Put the wires away from the joint. It has the same effect, but you haven't got the risk of an infection for that. An acute avulsion of the cartilage. Now, when you think of a TFCC injury, there are three ways it can be damaged. There's a central perforation, which usually is degenerative rather than traumatic. You can sometimes perforate it with a heavy landing, but usually it's degenerative. You can very rarely pull it away from here, the radial side, but we're talking here about peripheral detachments of the TFCC. So here we are, there's the peripheral detachment. And if it gets pulled off, you can repair the TFCC back acutely, either through a telescope or through open surgery. Which is best? Well, there's probably no difference at all in terms of the effectiveness if you do the telescope or you do them open. Here's arthroscopic repair using some special tool to use the stitches, or you can do them with a simpler technique. There we are, doing it through the arthroscope. And the other way is to do it through an open approach, which I tend to prefer because you can sometimes get more, particularly if they're a bit more chronic, to do it open. But there's the approach to the back of the DRUJ. So you have an incision vertically down ECU, and then you come all the way down here. And what you need to do is the TFCC runs across that way. So when you're exposing the TFCC, what you want to do, having excised this, open the skin, is to cut transversely between the TFCC and the triquetrum that way. And you cut transversely between the TFCC and the ulnar head there. What you must never do is come down here, because of course you'll cut it. So you have a limb like that. And if you do that, you can look inside here and look inside here, and you can drill your bone anchor into the ulnar head, put the stitches up through here, and then tie the TFCC down that way. And I'll show you some pictures, but here's the ulnar head exposed here. And there's a bone anchor going into the ulnar head just here. And we pull them back. The other acute injury is the TFCC tears or the TFCC is strong, so instead it pulls off a piece of bone and it pulls off the ulnar styloid. Now, if it's at the tip, it doesn't matter, it's stable. But if it pulls off lower down, then the TFCC is attached to it here, and then you're unstable through the ulnar styloid. And in those circumstances, you may need to fix the ulnar head back, for example, with wires in this kid, or with some sort of screw in this adult. And one more thing for you is this. You know, when you have a distal radius fracture and there's 50% have lost the ulnar styloid has been damaged, they don't need to be fixed. And there's been a meta-analysis here that shows that if you fix the distal radius, for most people, the small ulnar styloid fragment is left alone. You don't need to fix the ulnar styloid in a radius fracture if you fix the radius in a stable fashion. So far, we've talked about the anatomy. We've talked about acute injury, either because a surgeon has caused it or because the patient's had an injury where we've acutely damaged it, a Galeazzi or a dislocation, or a TFCC avulsion or a styloid fracture. So that's all acute. But now we're going to talk about how do we treat the chronic unstable DRUJ. And there's lots of ways of treating the chronically unstable DRUJ. And I'll just help you now and show you these. So we talked just now about the ulnar styloid. When the ulnar styloid is broken acutely, we usually don't fix them because most of them don't need it. But if you find someone has an unstable ulnar head, then if there's a broken styloid with a big fragment, you can repair it back on again. A tension band is pretty good. You can use a screw, but be careful with a screw because the screw's got quite a big head and it doesn't really grip that well here. And you can put the screw in and then burst the bone. So I think using a tension band is not a bad idea to actually repair these. Here's a patient who had a unstable DRUJ, and in fact, it was becoming a bit arthritic, you can see. But to stabilize this was too small really to mend with a screw or a tension band. So actually we took that out and then repaired the soft tissues here, the TFCC and the ulnocarpal ligament, back into the bone with bone anchors. And as you can see, some K-wires well away from the joint to hold it for 6 weeks. And that worked well. The DRUJ was not painful, even though it's becoming arthritic. There are some people who have an unstable DRUJ, often in the context of ligamentous instability, people who have got pretty lax ligaments anyway. And there's a small group of people who have instability of this joint, often spontaneous. And for them, shortening down the ulna, because if this is your TFCC and your ulnocarpal ligament here, and there's your ulna there, if you do an ulnar shortening, you pull this down like this. And so you're making this a tighter joint. So there's a group of people who, if you shorten the ulna down, will be sufficient to tighten the unstable joint. And that's very effective, particularly people with ligamentous instability without necessarily a previous acute injury. Attaching the TFCC. I talked about this to you just now, but there are different ways of doing this. And what you want to do here is to think about using a bone anchor. So here we are, we've done incision. You can see, I mean, it's hard to see here, but we're above and below the TFCC. That there now, I'm looking, so the TFCC is there, okay? I've cut beneath it and above it. There's the TFCC with a cut below, above. The bone anchor drill goes in there. There's the suture going into the ulnar head. We then take the suture, here's the TFCC here, so we put the stitch through the TFCC and then retrieve it above the TFCC here. Then you tie it down, reduce it, tie it down, There we are. And that's how you do the acute repair. Now, tendon weaves, there's lots of different tendon weaves. So if you go into the books, Greens or something, you'll see all these different ideas of weaving this and weaving that and doing this and doing that. And what's the one thing we know when there's lots of operations for a problem? None of them work. Otherwise, there's one operation. It's a bit like the unstable clavicle. There's all these different operations to hold them down, but that's because none of them work. And it's the same problem here, but the one that probably does work is the Adams procedure. So the Adams procedure is used when the ligaments are insufficient. And the idea is that you reproduce the TFCC using a tendon graft. And there are modifications of that. Here's Greg Bain's modification where he's using a tendon slip and a bone anchor. But the Adams procedure tries to reproduce the original ligaments. And here is one that I've done. You can see a drill hole here. So the palmaris longus graft goes front to back and it comes round the sides and then it drills into the proper space here. And here we are doing this. You can see the front to back, there's palmaris longus through the radius. There's a drill hole running through and we've tied it up. Maybe there's a small group of people where that sigmoid notch is so shallow on a CT scan that if you just open out the notch a little bit with a subchondral osteotome here, put a small piece of bone graft in just to deepen the notch at the back, a bit like a bone block operation perhaps up in the shoulder. Not commonly used, I don't think. And the final option, now we have the Sheckard prosthesis, is this. And the Sheckard prosthesis, the distal radial joint replacement, is a semi-constrained implant, and it's particularly useful for an ulnar head arthritis with instability, because until this implant, there was no procedure. If you're unstable and you remove the ulnar head, then you're even more unstable. So that's a silly solution. If you fuse a one bone forearm, that's not very functional. So this is the DRUJ replacement, and it's fixed to the radius, a long stem in the ulnar, and there's a ball and socket, and the ball has a hole in the middle with a stem. So as you turn, because you know the radius changes its length as you go ups and forwards, this stays in the gap. And there's an example here. And there are some results coming through the literature now with encouraging early results and encouraging medium-term results. And we're starting to get some longer-term ones now. There's a meta-analysis here with pretty good survival at 4 years. Now, 4 years means nothing for a hip replacement or a knee replacement. You wouldn't even get to market. But for these difficult problems, this procedure certainly does provide at least a short-term solution. We hope it's long-term. So here's my friend, who I think a lot of you know, working in Southampton at the moment, top man. And he looked at our DRUJ replacements last year for a project. And there's the design. You can see it's technically a bit complicated. And there we are putting it in. And we looked at 17 of our patients, the average of 5.5 previous procedures. One of them had 12 previous operations. So this procedure I've used for patients, and they've had cervical apangea, they've had a replacement, they've everything, and everyone's everything in the world to try and get this joint stable again. And the only thing that works is this procedure. And you can see our results. 60% thought it was, they didn't expect such a good result. 88% would definitely have the operation again. We've had one complication where the implant had to be removed, and she got pain. We still don't know why. We tried everything and we couldn't find out why. But otherwise, they're all in and happy. So how do I think about this? Well, the anatomy, we talked about the anatomy. It's important as always. There's a notch that's a bit unstable. You need ligaments, you need muscles, you need the capsule. We talked about instability. Doctors do not make this forearm joint unstable. Remember, don't cut off the edge of the branch that the monkey is hanging on. Not a good idea. It can be acutely unstable, and if it's acutely unstable, we fix the acute problem. We fix the Galeazzi, we repair the TFCC, we repair the broken ulnar styloid. If it's chronic instability, then we can treat with, depending on the cause, if the styloid is off, we repair it. If the TFCC is off, we repair it. If they've got ligament laxity, we can shorten the ulna. If the whole thing's really unstable, we make a tendon graft, an Adams graft, all the way around. And if you have a real problem, then it's possible to replace the whole joint and make it secure again. So that's my first lecture, everybody. I hope that was interesting. And maybe if we come off the screen share and back to the panel, Rami, if you could do that, we can have some questions if you like.
Thank you so much, our great professor, Professor David Warwick, for this marvelous talk. Thank you so much, sir.
That's my pleasure.
Dr. Rami will moderate the questions.
Thank you very much, Prof. As usual, smashing presentation. I have got a lot of questions. The first one is about the ulnar shortening osteotomy. How do you plan such patients to make a measurement about your ulnar shortening osteotomy?
So how short?
Yes.
Yeah. So the ulnar shortening osteotomy is only for a certain group of people. If you've ruptured the ligaments here, it won't work. You're just pulling the rupture away. But for people who are unstable globally, it's certainly a good solution, or a solution to try. How much do you shorten? I think it depends on the sigmoid notch, because if you think about the sigmoid notch here, and there's your ulnar head here, and the sigmoid notch is, say, that big, if you shorten too much, right, if you think about it, you're going to end up loading sideways too much joint. So you mustn't do it too short. Some people have got a very oblique notch like this, and if you pull them away, if they're oblique that way and you pull them down, that can cause impingement. So I think a maximum of 3 to 4 millimeters maximum. And you need to look at the notch and make sure it's not too much for some people.
Brilliant. Thank you very much. There is another question from about inferior fracture. You have mentioned your meta-analysis about it is not needed to be fixed for the ulnar styloid. When do you decide to attack the ulnar side with this radius fracture?
When do you fix the ulnar styloid?
Yes.
So if you have it's very rare, but if you have an ulnar styloid fracture right at the base and very early on, the joint's very unstable, then you can fix it acutely. That's actually quite unusual because the great majority of people with a distal radius fracture, the fracture has an ulnar styloid, but we know that they don't need to fix. Once you fix the radius, the system is stable again. So it's unusual, but some people have a fracture that's really low on the styloid, and right at the beginning, it's obvious that this joint's unstable. And for those, we can fix them acutely, okay? But we wouldn't fix them all acutely, only the ones which are obviously unstable early on. That makes sense.
Yeah. There is a question from Aladdin about DRUJ instability with carpal instability. When it is chronic, what is your plan of management?
For the
DRUJ instability with carpal instability.
When it's chronic?
Yep.
So that was the second half of the talk, really. If it's chronic instability, you need to see what the cause is. So if it's a chronic instability and you find the ulnar styloid is broken at the base, then we can try and fix the ulnar styloid with some bone graft. If the TFCC is pulled off because we do a scan or an arthroscopy, then we fix the TFCC. You see, if there's arthritis and it's unstable, then the only solution we have probably is the the joint. So it depends on the cause is when we actually know what we're going to do.
May I ask a question, please, sir?
Yes, of course.
The decision for fixation of the ulnar styloid, most probably, is pre-operative or intraoperative decision?
Well, that's a good question too. I think it's very painful. And if during surgery you find that the ulnar is, or the radius, the ulnar is really unstable,
yeah,
then you can decide during surgery. Most of them don't need fixing.
Yeah. So I have to be ready with the screws and the wires, everything.
Yeah, and the wires are good. You know, it's a small fracture, and sometimes the wires are safer, a little loop of tension band, because if you put a screw in, if you're not careful, it can. I've got an interesting question here from
Thank you, sir.
Mr. Mustafa Al-Rawi, who says, we don't have the luxury of ulnar head replacement. We always do DRAC for distal radial joint instability or arthritis, but do you think it's good for manual workers? Now, that's a good question. So if you have instability, do not do a DRAC, because if it's unstable and the problem's moving around, if you do a DRAC, you will be more unstable because for the reasons we've said. So don't do a DRAC or a Sove for instability, okay? If you have, and I understand these ulnar head replacements, you don't have them, they're expensive or, you know, they're very niche. I think as a principle, just remember, say someone's broken their distal ulnar here, and it's easy to say, you know what, I'm just going to excise the distal ulnar. Well, no, don't do that. Try and mend it with 1 or 2 screws or wires. If someone has a unstable distal radial ulnar joint, don't do a DRAC, it'll make it worse. Think about what we've just said. Why is it unstable? Why is it unstable? It's unstable because the TFCC has come off. You can now, I've shown you how to mend that TFCC with a little bone anchor and a repair. The stylo's off, you can repair it with a tension band. So think about why it's unstable before you do something like a DRAC. For osteoarthritis, if you have no choice and no implant, then try steroid injections. Try to reduce activity, try other things. If you do a DRAC, my recommendation is you do rather than cutting off here, you do the matched resection where you actually keep as much length as you can. And with the arthritis, I use a small saw and I just, if that's the ulnar head here, I use use the ulnar head and just, but keep the length and keep the roundness of it. So at least you've still got an ulnar head against the sigmoid notch. But it's a good question. We don't have these implants, you know, they're expensive and they're not everywhere. But just before you do a DRAC or a Sove ask yourself 10 times, why is it unstable? And can I do anything else before I just cut it out? No. Oh, you're muted.
You're muted, Dr. Rami.
That's better.
There is a question about what is the appropriate time for radial head excision after acute trauma.
I think I missed that. What's the optimal time?
Yes, what is the appropriate time for radial head excision?
A radial head excision up here.
Yes.
Well, that's a good question. You could say never. You could say sometimes it's so broken. What I would say is that if I was the consultant and whoever was the surgeon on duty with me, the registrar, fixed the radial head badly because it was a bit broken, but he put some screws and some wires and things, and it wasn't perfect, I think I'd say, well done. That's fantastic, because I would rather see someone fix it as best they can, even if it's not very good, because, okay, in 6 or 8 weeks later, you could probably then remove the bad fixation because all the ligaments and things have now healed at the proper length. The problem is if you take it out early on. So you could remove this thing, you can put in a cement spacer up here. If you have a cheap radial head replacement, you can put one of those in. You may not have one. But if possible, don't take out the ulnar head. repair it. And even if it's difficult, and even if it's not perfect, I think it's better to repair the radial head and let the soft tissue settle, and then you can always come in a 6 weeks or something and take it out and start again.
Thank you. There is one question from Shebla Imara about DRUJ.
I think you've frozen.
Dr. Rami, the question, sir, with that. Yeah. Okay, go ahead, Dr. Rami.
There is a question from Shebla Imara.
Oh, yeah.
About
I can see the question, yeah.
Dr. Rami? The question, sir, with DRUJ or Kapanji, you reinsert tendon to the end of the ulna like flexor carpi ulnaris?
No, I think those operations are silly, because if you look at the forearm here, right, when you rotate like this, because your ulna's fixed, your radius crosses over like this. So radius and ulna, and then when you pronate, they cross, see, and it gets shorter. So when you rotate, the radius and ulna are always doing this. So if you put in I've seen these diagrams, a piece of flexor carpi ulnaris or something here to make it stable. There's two things. Firstly, as you rotate, it won't be stable anymore because this distance changes. But secondly, the instability isn't in this direction. The instability is this way. So having a piece of tendon here doesn't stop it from going this way. So I think the answer to that question is, don't do a Sauvé Kapanji. Don't do a Sauvé Kapanji. Think about something else. What else can I do that makes the anatomy normal if it's possible? Not always possible, but if it's possible.
Okay, we can move to the next presentation, sir.